Dr. Jessica Mason. I am an assistant professor of clinical emergency medicine at UCSF Fresno, and I'm also the chair of the California ACEP AdvancED Conference. It is such a pleasure to be here with you this morning, but I have to say, this was a bit unexpected, right? We weren't expecting to meet in this format. We were expecting to be in beautiful San Diego, but here we are I am in beautiful Fresno, broadcasting to you from my home, and we are broadcasting on this platform called Big Marker, which we hope works out well for everyone. So bear with us, because as many rehearsals as we do, something always seems to go wrong. But you know what? We're going to roll with the punches because we're ER docs. That is what we do. So this year, the conference is obviously digital, which has a lot of upsides. We are able to really draw in a bigger audience and all sorts of different speakers, and everyone's saving a boatload on traveling to San Diego. So that's a good thing. The theme this year is inspired. And before COVID struck, we chose this theme, and we were thinking about, what inspires us to go to work? What inspires me to keep going to work? And I think when most of us started out on this journey into medicine and into emergency medicine, at least I had this very pure idea of wanting to help people, wanting to answer to a higher calling and to be there for people in a time of need. And really never before has this been so apparent since COVID struck the world this year. It really has highlighted this need for us as a specialty, and for you, and the amazing career that you've chosen. And so thinking about what inspires us, one thing for sure is being there for patients in this great time of need. And I know that COVID also makes us stressed and burned out, but I hope we can also see the silver lining, that this has really shown the world the importance of emergency medicine and how important it is for you doing what you do. Now, another thing that really inspires me to go to work is you. Yeah, you, the residents, the medical students, everyone out there who keeps me on my toes. It makes me want to be a better educator, because I know that I get to serve you, and I have a lifelong of learning ahead of me that I want to share with medical students and residents, and you always push me to learn more and do more. And this conference is for you. The last few years, Cal ACEP has pivoted the focus of the conference to be all about the medical students and the residents. And so after this first hour of the general session, we're going to dive deeper into some advice for residents, and then we're going to dive deep into advice for medical students in the medical student track. And finally, one other thing that really inspires me is great educators. And I hope that we're able to share that with you today with some of the speakers that we've chosen, and notably with our keynote speaker, who I'm going to introduce in just a minute. Finally, another thing that is very inspiring and has inspired this conference is advocacy. That is the heart and soul of California ACEP. It's not just being there for you as an emergency physician on the ground, but also what does that mean with legislation and all the amazing things that Cal ACEP does to advocate for our specialty. And we're going to hear more about that as well during this first hour. So I have to give a few thank yous, because a lot of people worked really hard to make this conference possible. So thank you to California ACEP and the amazing team that is working hard behind the scenes that you can't see. You can't see Kelsey McQuaid, but she is the producer and the everything who is making this conference happen. So Kelsey, you're amazing. Thank you so much. Also, the rest of the team, Lucia Romo, Hannah Sanders, Lauren Murphy, everyone's working really hard to try to pull this off for you, and we hope that it goes over well. We also want to thank California ACEP and our sponsors for making registration free this year. That was a really, excuse me, that was a really big deal to try to make this free and accessible for everyone. And we have one more sponsor I want to particularly acknowledge, and that's MRAP, Emergency Medicine Reviews and Perspectives, who has given us a huge lift in terms of making this conference possible and supporting our tech and supporting some of the video editing that you're about to see. If anyone knows the most about how to put on a live digital conference, well, that's MRAP. And I've had the benefit of learning from MRAP. So hopefully that's given us the boost to make this a success today. I want to also acknowledge the leadership that has helped organize the conference, my co-chair, Natasha Wheaton, the track chairs, Shen Lee, Annalie von Reinhardt, and Andy Grock, and we will hear from them in a little bit. And I also want to mention that, remember how I said we were going to meet in San Diego? Let's do that next year. As long as it's safe, we're going to do that on September 10th, 2021, which is certainly going to be a better year. And we will see you in San Diego at the Westin at the Gaslamp District for hopefully a live in-person conference where we can all be together again. Now, I mentioned that we're using this platform, Big Marker. Okay, it's new to us, but I want to point out a couple of features. First of all, the chat feature. We want you to use this. Use this as a space to post your questions, interact with each other. We've invited all of the speakers to be present and to be able to chat and interact with you and hopefully answer your questions in real time as they're giving their pre-recorded talks. There's also a link you can click on for handouts, and we have a few key handouts there: the schedule for the day, the residency fair schedule, and then some information about Cal ACEP and how to get more involved. So, quick overview of how this day is going to go. The general session is first. This is for everyone. Here we're going to hear the keynote. We're going to hear from the Cal ACEP president. We're going to learn more about advocacy and some more. And then we'll take a short break and we'll focus on our resident track. We'll take another break, brief break, have some lunch, listen to some music, and finally we'll do the med student track. And then later this afternoon, we are doing the residency fair. Now, normally that's in a big ballroom and you walk up and you get to talk to program leadership from places all over the state. Well, no one really knows how to do that in a digital format. We're going to give it our best try. And Dr. von Reinhardt will explain the details of that later on today. But we really want to make it interactive and give you that opportunity to talk to program leadership. We have 22 out of the 23 programs in the state of California who are going to be represented in our residency fair later today. So that's an amazing show. And hopefully you get a chance to use that and meet some of the amazing programs from around the state of California. And so now I would like to bring us to our first speaker. Our keynote speaker for today is Dr. Mel Herbert. Mel is the founder and CEO of Emergency Medicine Reviews and Perspectives. And as I mentioned, the theme today is inspired. And I thought, who inspires me the most? That's my mentor, Mel Herbert. He is an amazing educator. He is an amazing mentor and friend. And he is dedicated to learning and education. He has stepped up to try to provide education in this crucial time as we have been dealing with a specialty with COVID-19, and to provide free content as well about COVID. Mel has dedicated himself to being a lifelong learner. And so in that spirit that I hope we all can share, I would like to introduce our keynote speaker, my friend and mentor, Dr. Mel Herbert.
Ladies and gentlemen, boys and girls, my name is Mel Herbert, and it's really my pleasure to speak to you. I really want to thank Jess for asking me and for Cal ACEP. And so Jess said, do you want to talk about maybe how COVID is going to change emergency medicine and education? And I thought that's a really interesting idea. COVID's going to change everything. And I certainly have no specific insight about how it's going to change emergency medicine or education, but I'm happy to spend just a little bit of time with a few of my thoughts, because this is an extraordinary time. If you are having a hard time getting your head around this, that's normal, I think. When I talk to patients that went through the Second World War, my grandparents that went through the Second World War, actually my mother was in England during the bombings. When you talk to a lot of those people, there's this weird look they get, like, did that really happen? That I was in this world war, the entire world was fighting and people were dying and it was just overwhelming. I think that's a little bit about how we feel right now. This thing has changed everything, and it's really hard to get our head around. I don't think we'll fully grasp it until years later, and we too will look back at this time going, did that really happen? It's just a little bit too big to get your head around. But in terms of how emergency medicine and education might change, here's a couple of ideas. The first one might be a little obvious, but the first one is that the textbook is dead. Now, the textbook has been dead for a while, and this is sort of one of my pet peeves. I love textbooks. I have lots of old medical textbooks from when I was in medical school and residency, and I keep them around because I just like them. I haven't had to move in 25 years, which is good. And I might have chucked them out if I had to move, but I love textbooks. but they're slow, they're expensive, they're heavy, and in a pandemic, they're completely useless. If you go to the latest, greatest textbook, there's nothing about COVID-19 in there, but we desperately need COVID-19 information. So the textbook manufacturers' profits have been going down for years, but I think this is it. I think this is sort of the death knell for traditional textbooks and traditional learning. So we started our online textbook in October of last year. It feels like forever ago in COVID years. But we created that thing specifically so that we could have a rapidly updatable online clinical reference text. And within 6 months of starting this thing, along comes COVID. And a number of us, particularly Jess and I, within MRAP said, we really should have a COVID chapter. And then we thought about it, it's like, that's going to be too much. There's so much information coming in. We're going to have to update that every day. So we went away and thought about it for another day. And like, well, if not us, who? So we better do it. So Jess and I wrote that first chapter, and we got some experts to help out. And we literally were spending every day redoing it and adding new information. And within days of starting that project, we had it online. And since that time, we've handed it off to new people. We've had more experts come. I actually tried to get ID experts from across the country and indeed from across the world to write it. But all of the ID experts said, I haven't got time to help you. I'm dealing with my hospital response to this thing. But it showed me that this idea of an online textbook is the only way to do this thing going forward. Because you can add the multimedia, you can add the audio, you can add the video, but you can also change the written material very quickly. And it's not just us, of course. UpToDate has resources, and blogs and other places do it as well. And I think that is the future. I think the textbook as you know it is going away, and the textbook as you know it should go away. We even did live shows here in the studio based on that textbook chapter, and talk about changing medicine. We used to do live shows where if we got 500 people, maybe 1,000 people to watch a live show, that would be amazing. During the time of COVID, that first one we did, we had over 20,000 people watching in real time as we discussed this outbreak. So medicine has changed a lot. It's moved online, and education has moved online. And I don't think that's going to change, because the technology, that's just where it is now. Now, the other thing that I think is going to change and should change is telemedicine. So the ER is an absolutely filthy place. I don't know if you knew this. It's disgusting. Despite how much it gets cleaned, it's disgusting. And here's an example. At County LAUSC, residents would get their PPD done at the beginning of their residency. And they did an internal survey and found that over 60% of those residents, by the end of their 4-year residency, had gotten PPD positive. The ER is a filthy place. In a pandemic, guess what? It's a filthy place. You take all of the community spread out there and you funnel it to the hospital, and where do they all come through? They come through the front door of the emergency department. And our patients and our non-patients understood this very well. And when we said stay away because there's a lot of COVID here, everybody stayed away. They were having their heart attacks and their strokes at home. It was bad. We overdid it, actually. We told them to stay away, and we should have said, please come if you're sick, but if you're not sick, that's okay. But telemedicine has it's been around for a while, but during this time, we've used it an enormous amount, both in the hospital and outside the hospital. But this is where I think medicine should be going more too, because it turns out that a good history and a video camera can get you 99% of where you need to be for a whole bunch of patients. They don't need to come to the emergency department. They shouldn't come to the emergency department. And if they don't need a suture or a splint, or to actually have hands put on bellies, then they probably shouldn't come. So I think medicine will change substantially. I know lots of people in private practice here in the United States, and for them, telemedicine is going to be a big part of what they do going forward. If you've got a rash or something and you want to go see your dermatologist, how much better to do it at home? Same for the emergency department. I'm not sure if this thing's really bad. Let me call into the ER, talk to the doc on the telemedicine thing, and be billed for it in an appropriate way, get fixed, not have to go to the emergency department, not have to drive, not have to take the kids out of school, whatever it is. I think you're going to see a lot more of telemedicine in all parts of the world, even once this pandemic is gone. Now, the next thing I want to talk about could be viewed as political, but I really do not mean it in that way, as in a left-right kind of way. But I think what this pandemic has shown us is that science matters. Science really matters. And we are going through a dangerous trend not just in the US, but in other countries as well, that science doesn't matter. This anti-science and anti-scientist meme, I think, is quite dangerous. If you look through human history, other civilizations have gone through this, where groups of people in that civilization have decided that science doesn't matter and religion or other things are more important, and the two can't stand together, so we will go the route of non-science. And great civilizations have fallen because of that. And I'm very concerned that we are going through that time right now. That as we have this sort of populist uprising, for some reason, that means that people don't like science. They proclaim themselves or their tribal leaders as experts. That those people who have studied this thing for their whole lives, well, they don't really know it more than I do. And Dr. Fauci has been one of those people saying, look, I'm really concerned about this trend. You can be an anti-vaxxer. If 70% of the rest of the population get their vaccines, your kid will be protected because of them. You can get away with it when there's not a pandemic. You can be a flat earther your whole life because basically it doesn't matter whether you believe the earth is round or if it's not round. But when there is a public health and science catastrophe that we have just had, you can't ignore the science. If you do ignore the science, then people will die. You cannot proclaim yourselves or your movement as an expert in the face of something that really matters. I mean, it seems so blatantly obvious, but it doesn't become blatantly obvious until you have something like a pandemic. I would not go into the operating room and try and take out somebody's brain tumor. But that's what people who know nothing about public health have been trying to do and say, oh, we don't listen to those public health people because we know better, because we've got degrees and PhDs in fields that are completely unrelated. It's insanity. So I'm hoping that this will show that science really matters, that being science literate, just like you are, being science literate, being able to read the literature, being able to weigh the pros and cons, being able to understand a good study from a bad study, being able to understand sometimes good studies are wrong and sometimes bad studies just by accident get it right. And that you have to have a Bayesian way of thinking about these things, and you have to have the ability to be malleable and change your response when new information comes in. We need to be science literate in that way. And that can still result in very different outcomes. And the great example is you've got Sweden and New Zealand, the public health services. If you look at their data on the public health services of these two countries, they basically agree on the science. They basically agree on how infectious COVID-19 is, how many old people will die, how many young people die, how it gets transmitted, the use of masks and all of this stuff. They basically agree on it completely. But in New Zealand, they decided to lock down and do contact tracing and try and really damp it down. And that's how they were going to deal with it. And Sweden said, well, we're just going to do something a little different, keep it open, let the young people out there, maybe we'll get some herd immunity. And two very different ways, and I think two reasonable approaches. You could argue for both. We won't know for many years about which approach was best. It might be that the Swedes got it right, and eventually everybody's going to get the virus anyway, so destroying your economy is not the right thing to do. Maybe New Zealand will get it right. Maybe we will get a vaccine fast enough so that that suppression of the disease and the vaccination of millions of New Zealanders will mean that in the end, maybe they will be right. We won't know for years to come, but the same science resulted in two very different scientific approaches to this disease, and I think that's perfectly appropriate. We can disagree about what to do with the science, but we can't disagree that science is not important, that anybody out there can be science literate when they're really not. And finally, what has this pandemic shown me, or what has it changed? Well, I gave a talk at ACEP a couple of years ago, and I talked about the fact that in my lifetime, we had a pandemic and we got through it and we were scared. And every day we weren't sure whether our patients would give us this terrible disease, and it was HIV. But every day, residents and attendings and nurses across the country came to the emergency departments when we were seeing tremendous numbers of HIV positive patients, and we looked after them. And now I see this pandemic and I watch a whole new generation of docs and nurses and healthcare professionals every day go to work, and they're afraid. They're afraid that the disease that they're trying to help with their patients could infect them, could kill them, could really hurt them and their family. They could bring it home to their little kids. They could bring it home to their grandparents. They're afraid, but they go into work every single day. They wear N95 masks for 12 hours at a time. When they take it off, they pull the flesh literally off their skin, and we've seen the pictures of these people over and over again. They keep going in, and the world has seen, appropriately, the people that are working on these front lines as heroes, because they are. You know, there's two types of hero. There's the accidental hero. That's the person who's walking past a burning building and sees that there's somebody in the building and jumps through the window and pulls the baby out of the burning house, and that is an accidental hero. They didn't wake up wanting to be a hero, but in that instant, they did an incredibly brave thing. But there are people that have argued that even more powerful than an accidental hero is something that some people call the deliberate hero. The person who has put themselves continuously at risk, knowing the dangers, and have gone back into that building over and over and over again. And the people that are working in the emergency departments and throughout the healthcare system right now, I tell you, are deliberate heroes. They're afraid. They're afraid that they're going to get this. They're afraid that they're going to get sick. They're afraid they're going to look like that 200-pound, incredibly muscular nurse who got this disease in his 30s, who literally came out of the hospital barely alive, a 90-pound weakling, almost dead. They're afraid of that, but they go to work every single day. They've been called heroes because they are. And I think many of you that are listening are students and residents, and you are thinking about emergency medicine, or you're in emergency medicine. And it's the best reason to do emergency medicine, because the people that do it are heroes. They're not accidental heroes. They're deliberate heroes. And you can be one of those, and you can work alongside one of them. And there is nothing more inspiring than that. Have a great conference. Thanks for listening.
Hello, my name is Dr. Vik Gulati, and I'm a practicing emergency medicine physician in San Diego, California. It is with great honor and humility that I introduced myself to you as your next California ACEP president. I'd like to take a moment to tell you why, in my mind, California emergency physicians are superheroes. I don't use the term superheroes lightly. In the middle of a pandemic, each of you have proven to your communities and to our state that when you need us, we won't just be there. You will bring passion, expertise, and the unbelievable ability to quickly problem solve around any constraint to keep everyone safe. You are superheroes. And for the first time in our specialty's history, everyone around us recognized it. Our communities were rightfully cheering us on as we risked everything, including our own safety and our loved ones' safety, to keep the community safe. Our medical colleagues realized that when the world's health was in jeopardy, we, as emergency physicians, would represent the House of Medicine. And you had each other's backs. When PPE was short and supply chains seemed non-existent, California emergency physicians started to engage to solve the problem. Members like David Tursa drove miles around Northern California to visit home improvement and gardening stores to acquire all the N95s he could get his hands on. Dr. Nicholas Taylor joined up with the National Get Us PPE team, and countless others, including a team from UCSF, started using 3D printers to develop intubation boxes when there was a concern of PAPR shortages. From the start, all of you have wanted to do more and go where help was needed, even if it meant going directly into the epicenter. When Governor Newsom requested a California healthcare delegation to assist our New York colleagues and fellow humans, multiple Cal ACEP physicians answered the call, such as Doctors Carrie Ann Drenton, Tom Sugarman, Chi Porla, and Nick Sawyer. They represented our state, our specialty, and our organization with honor. Even if you couldn't directly help by being boots on the ground, physicians like Dr. Bhavesh Modi of San Diego started thinking outside the box. He realized that cell phone chargers could keep patients connected to their loved ones and limit PPE usage. He was instrumental in developing and starting a nonprofit called Charge Power, which has shipped over 6,000 chargers to 87 emergency departments and hospitals to date. Today, I'm coming to you from the MRAP studios, the powerhouse of medical education that our colleague Mel Herbert built. And when all specialties needed knowledge about COVID-19 quickly, they turned to us, the House of Emergency Medicine, to get them up to speed. You are superheroes. I was inspired to become an emergency medicine physician by my uncle, the late Dr. Adarsh Soni, one of the first board-certified emergency medicine physicians in the country. For everyone who had the privilege of knowing him, he was the gold standard of doctoring. And he made me believe that emergency physicians could do anything. When Dr. Soni started practicing, it was often said an emergency physician is a jack of all trades, but a master of none. He never believed that. And to the medical students who are our future, and the new residents who join our ranks, let me be the first to tell you that Dr. Soni's vision has come true. Our superpowers have grown. We are now the masters of all. EM is the gold standard of doctoring. We rightfully train out of emergency departments by fellow board-certified emergency physicians. It helps us understand our foundation and reaffirm our drive to be the safety net of the healthcare system. It is how we earn our white hats. And thanks to Cal ACEP chapter leaders such as Drs. Mike Bresler, Ron Kroll, and Larry Bedard, who fought to have EM recognized as a specialty in its own right, now emergency medicine physicians are everywhere, and we touch all parts of medicine and beyond. When we are in the hospitals, we're no longer just in the emergency departments. We can be found in the ICUs as critical care physicians, alongside our admitting colleagues as EM-IM or EM-FM, or helping patients with end-of-life decisions as EM palliative care. We train the future generations of all specialties in simulation education. We dominate radiology with our ultrasound skills. And of course, we're leaders in the hospital. Colleagues like Dr. Tom Russell of Sacramento have morphed an entire healthcare system into realizing the importance of sepsis care from start to finish. And outside the hospital, our reach only broadens. We are EMS-trained medical directors, helping California counties manage unbelievable COVID surges. We are spreading acute care knowledge into urgent cares, as higher acuity patients are presenting to these establishments. And lately, we are being thrust into telemedicine as the world changes and everyone recognizes our ability to triage and provide timely care. We have always been the leaders in disaster, event, wilderness, and international medicine. We bring emergency and acute care medicine to anyone that needs it. Now, my parents are Dheeraj and Vik Gulati, two non-physicians who produced two physician children. While they may not have taught my sister and I the Krebs cycle or how to tie a surgical knot, they did teach us compassion, empathy, and the importance of coming together as a family. Because family gives you the guidance to evolve, grow, and become your best self. And that's what California ACEP is. The family of California emergency physicians. It is where I have met some of my most trusted mentors, such as Dr. Andrea Wagner, who leaves a lasting impression on me after every thoughtful discussion. It is where I've learned from some of the best leaders in medicine, such as Dr. Vivian Reyes, my predecessor, who has repeatedly demonstrated that as a leader, everyone's voice should be heard. And California ACEP is the forum where ideas are debated, best practices are considered, and one unified voice is established. We are stronger together. Together, we are superheroes. At the start of the pandemic, we heard from many of you, scared to return home because of the risk of accidental transmission of the virus. California ACEP immediately created a coalition of other medical specialties and engaged with short-term rental platforms like VRBO and Airbnb to advocate for affordable and safe alternative living arrangements. With the threat of financial loss and possible insolvency, California ACEP advocated for state funds to ensure the safety net remained intact. We know from many of you, and especially our newly minted attending physicians, shift cuts or permanent job losses are significant and stressful. We continue to address this at the highest levels to ensure you have the financial security you deserve. We recognize the practice has changed in the midst of the pandemic, and we continue to advocate for liability protection and the acknowledgement of the uncharted waters we are all asked to navigate. And while the legislators have publicly praised and thanked you rightfully as essential superheroes, we at Cal ACEP continually remind them to put their money where their mouth is and ensure emergency physicians are appropriately compensated for the unmatched community benefit you all provide. Rest assured, California ACEP has your back. Our mission statement is to support emergency physicians in providing the highest quality of care to all patients in their communities. Our history is rich in achieving this mission and being on the forefront of ideas as we fight for our specialty in patients. We were leaders and advocates to eliminate patient dumping in the 1980s. We continue to reinforce the prudent layperson standard even today. And recently, we pushed to support systemic changes to opioid usage and treatment thanks to the vision and work of Drs. Ronit Lev, Amy Mullen, and Rev Close. But as we move forward, we are faced with new pressing challenges. We continue to lead by example. Racial, social, and gender inequalities are plaguing our nation and our healthcare system. California ACEP takes an affirmative stance against these injustices. We will continue to support the work of our members in all these areas. And a prime example is Dr. Omar Guzman from Visalia, who has been highlighting the social determinants of health and creating a street medicine program to take the practice of emergency medicine to where it is needed. Acts like these will continue to teach the next generation of EM advocates the challenges our patients face. Furthermore, as the state faces unprecedented climate changes, members like Dr. Mark Futernick of Pasadena continue to bring awareness to the health effects of climate change for our patients and our members. We are superheroes. To quote a line from my son Caleb's favorite superhero, Spider-Man, with great power comes great responsibility. And that's what Cal ACEP is, accepting that responsibility. The responsibility to band together to advance ideas as one. Because together we can continue to be the solution leaders. But it will take all of us to join to become that one unified voice. So I welcome you into the house, and I welcome you into the family. Together, we will represent the gold standard of doctoring.
Morning, and thank you all for joining us today. My name is Vivian Reyes. I'm the immediate past president for Cal ACEP. And one of the things that Cal ACEP is particularly proud of is our advocacy. And so we are extraordinarily well respected in the state capitol, and we are a punch above our weight class with respect to other interest groups in California. So even in national ACEP, we are considered leaders in advocacy. So a lot of people ask us, what is the value that Cal ACEP brings to you? And I would say that advocacy is really a big part of that. Advocacy is what we bring to you, your practice, and your patients. So just as in previous years, today we are going to give you a deeper insight into what we do and some of the main issues of this year. So I'm going to just introduce Elena Lopez-Gusman. She is our Executive Director for Cal ACEP. And so Elena, I just wanted to see if you can tell us a little bit about our priorities for the year.
Sure. So like everything else in 2020, they changed up several times. We started out the year in January with a set of priorities that included mental health access for our patients. So focusing on things like making sure that there are the right panoply of services available in communities for our patients, and then also ensuring that we are able to effectively transfer patients to those resources. So mental health was a big priority. We were also, the governor in his January budget laid out an ambitious plan to transform the way that we provide Medicaid services, which in California is Medi-Cal. And he called that initiative Cal-AIM. And Cal-AIM was really about, I would say, kind of looking at healthcare more broadly than the narrow healthcare focus that we have had in the past. So things like including transportation services and housing and, you know, sort of a whole being approach to healthcare. And so the board in January felt like that was a very important priority for the organization to weigh in and think about how the emergency department and how emergency physicians can play in that, and being, you know, part of the hub in terms of the hub and spoke of care coordination and really playing a role for our patients. So as well as some scope of practice issues. So scope of practice really just means what areas are professionals able to practice in? What is their scope? And particularly for us this year, we were looking at two things, and that was what can paramedics do in their scope of practice and what can nurse practitioners do in their scope of practice. So I would say those three main issues were what we were looking at in January. And then March hit, and the world went topsy-turvy for everyone. And so we had to readjust. And the board looked at what are the priorities of our members now in this new world order. And so we started focusing on things like adequate PPE supply and you know, liability protections for physicians practicing in a whole new environment, as well as, you know, recognizing, you know, after the sort of the first month of the shutdown, it became obvious that we had really low ED volumes. And so because of the way healthcare is financed, that meant that groups who are contracted to provide services in emergency department and individual physicians had less revenue. And so how were we going to be able to talk to policymakers about our responsibility where we're now being asked to do more with less resources? And so we started having that conversation in our advocacy arenas. And then I would say, you know, the world kind of shifted again. And in that period of time, the legislature wasn't even meeting. So I've been doing this almost 25 years now, and it's the first time where the legislature was sort of irrelevant. I've never seen anything like that. And the governor was issuing, as I'm sure you all remember, executive orders after executive orders and having all these news conferences, and the legislature was largely irrelevant. And so that was a very different atmosphere than anything that we've ever experienced before. And it changed our advocacy, of course. We had to respond to that. And then in the last couple of months of the legislative session, which just wrapped up on August 31st, The legislature came back, was slightly more relevant, although in a whole weird way, which we can talk about later. We started kind of refocusing on, there were still some COVID priorities, a lot of attention paid by the legislature to PPE, but then also our highest priority was trying to defeat AB 890, which would allow nurse practitioners to practice independently without any physician supervision. And so that became our top priority for the close of this year.
So Elena, I know this scope of practice issue has been around, as long as I've been on the board. I know it's always been challenging, but it's never really gotten this far in terms of the state legislature. So what's changed?
Yeah, it's really interesting. So it has been around for, I want to say the earliest bill was probably 2013, and there have been 3 bills in the last 7 years. So 2013, 2015, and then again 2019-20 session. And you're right. The bills have gotten a lot of attention, but in general, they've moved fairly far along in the process. But certainly not gotten the momentum that they did this year. And the House of Medicine in general, which is, what we call all the specialties together under the CMA umbrella, the California Medical Association umbrella, we're really able to keep those previous issues at bay, or those previous pieces of legislation at bay. And as I reflect on, what are the differences for this year, I think there are a couple. One is that the author of any legislation matters. So for example, when we are going to sponsor legislation, we think very thoughtfully about who do we want to carry this piece of legislation, who's the right champion, who's the right voice, what influence do they have, and so that is a factor. And so when legislators, for example, are torn on an issue, it's not going to be the determinative factor. But when legislators are torn on something and they don't quite know how to vote, or they think that both sides make good arguments, then things like their relationship with the legislator is going to matter. And I don't just mean things like a personal friendship, although that could be it. But it could also be like, do I trust this person? Has this person supported things that I'm generally aligned with? So do I think like them? Are they trustworthy? Are they, those kinds of things. And so, there's definitely a difference between the author of the previous rounds of legislation and this author and their kind of stature with other members. And so I think that was probably a factor. But also, and we know this from pushing ideas of our own, big changes take time. And so lots of times, you have to, and that's sort of the way the democratic process is set up in general, but certainly, it's also true just of human beings as individuals. It's hard to make a big change unless you've had time to kind of internalize it and be ready for it. And so it's no different in the legislative process. And so having this issue be around and talked about for 7 years makes a difference. People have become more used to the idea. When you first say it out loud, it sounds crazy, but 7 years later, you've heard it so much, you're sort of desensitized to it, right? It sounds a little bit more normal. And then the underlying problem, which is stated for why we need this, which is access to primary care, a lack of access to primary care, hasn't gone away. And so that creates an additional kind of impetus to act. Because what the authors have said is that we lack access to primary care, which is real. And so then this, at first it's like, well, yes, that's true, but this isn't the correct solution. But when you still have the same underlying problem and any things that you've done in the meantime haven't fixed it, then there's sort of more urgency on the legislature to say, well, yeah, but that's still a problem. We have to try something. We have to do something. And that gives a little bit more urgency to this kind of a change. So it's interesting because the arguments they made were the same. I went back and I actually looked at the recording, because all this stuff, not that any of you want to look it up, but it's all archived and you can look up speeches from legislators, very far back. So I went back and I looked at the one from 2013, and it's almost as if it was transcribed and then reread by the current author. Like they were the same points, just, almost verbatim. It was really sort of stunning. About lack of access to primary care. Many other states do it. There's no evidence that it doesn't work. We have anecdotes about, things, but we don't have any studies that show that nurse practitioners, that patients actually receive worse care. And so those are those talking points, and they just keep beating them over and over, and here what we got here.
So it's interesting to bring that up about the access to primary care, because that's sort of what the author is saying that this is about. Yet the bill actually isn't just limited to primary care. It's really across all specialties. And so I do want to just talk about, what do we do when there is a bill that comes out that affects not just emergency medicine, but really, all specialties in the whole house of medicine. And so I think it's important to note, because we do different things. So when it affects the whole house of medicine, we will typically try to go in as one voice. So we will support the CMA, and we are usually stronger with one voice across all specialties. And so I know we really tried to do that in this case. It's being a good team player. It's really, supporting your other specialties as we would want to be supported. And so that has always been our mantra is, if an issue affects the house of medicine, we will stick together with one voice. There are times, though, where Cal ACEP has gone off and asked for an exemption. And so this is one of those cases. So the way that this case went down is, earlier this year, we recognized that this bill was going to move forward. And so Cal ACEP was faced with the decision of, okay, we have spoken as one voice, we have supported the CMA, this is going to pass. So do we want to continue supporting as the House of Medicine, or do we want to peel off and ask for an exemption for ourselves? So this was actually a really interesting discussion that we had with the board, because the question is really, do we want to save ourselves and say that, okay, if the emergency departments are exempt from this, we will go neutral, meaning that we're okay, we're not going to oppose the bill if we get exempt. And the argument against doing that was, I'm opposed at any cost, and I am not going to condone. I'm not going to condone that, and we should be opposed at any cost. And so there was a lot of debate and a lot of strong opinions in both ways. And, really it came down to, okay, at the very end, we stuck with the House of Medicine, but we know that our members would want us to fight for us in the emergency department, and we do represent emergency physicians. So we did ultimately ask for an exemption on this, but it was not without a lot of discussion. And so, Elena, can you just tell us, how did it go through the legislature after, we made that decision to, ask for an exemption? How did that go?
So it's really interesting because, we do have a history of doing exactly what you described, which is, sticking in there with everybody. And then, when it gets down to the end and it looks like it's, a certain policy is going to go, asking for an exemption because of the unique situation in the emergency department. And we've done that on a variety of things. For example, one that you're probably all familiar with is the requirement to, look up in Cures, the state database, before you prescribe an opioid. And we were able to, that was largely opposed by the House of Medicine all the way through. It was a 2-year bill, much like this one, where there was a lot of opposition, and then it looked like it was going to move. And, the House of Medicine couldn't stop that. Similar again to this issue, it was, happening in a lot of other states. There was a need to do something about opioids. So again, that sort of legislative push to we must do something. And, ultimately we were able to say, the emergency department is different. That login is cumbersome. It's difficult. It takes time. We'll use it when we can, but don't make it mandatory, because there are probably instances where, we don't have the time or the situation doesn't call for it. And so we were able to successfully do that. In this instance, similarly, I think, there's a very strong case for why nurse practitioners should not be able to practice, not just alone without supervision, but be the only practitioners in an emergency department. There's nothing in this bill that requires physicians to be practicing in the emergency, or I should say it this way, there's nothing in the bill that would prohibit a hospital from contracting solely with nurse practitioners to staff an emergency department, which, I don't think is necessarily going to happen tomorrow, but, you have to sort of look at where, what incentives and disincentives are being aligned in the law that could allow for changes in the future. And so, I think that, one of the things that we heard from legislators is, well, I only see the nurse practitioner when I go to the doctor anyway, sort of like this sort of feeling that, well, it already sort of exists in primary care, so what's the big deal? Whereas I don't think that's the case at all in the emergency department. People do not have an expectation, either legislators or the general public, that if they have an emergency, that they're going to go to an emergency department and there's going to be no physician. So we really felt like we had a compelling case to ask for an exemption. And I will say that it was, I didn't really realize until we were going through it how different the whole COVID experience made lobbying this year. You create, there's an energy that exists in the Capitol, and especially at the end of session, everything's crazy and it's filled with people and you're lobbying each other in the Capitol, and nobody was in the Capitol. I mean, legislators were in there, but they are only allowed just legislators and one staff person per legislator. So even though they may have a staff of 10, only one person could be in the office at any given time. So, and the lobbyists weren't going in there. You could just call or email. We're often effective by being squatters. We just go into people's offices, unannounced with no appointment, and just wait until they'll take our meeting. And that's, not being shy or embarrassed to do that makes you an effective lobbyist. But you can't do that. You can't force somebody to take your call or read your email or respond to you or have a conversation. And so that was very different. And then also kind of this energy that I'm talking about. So there's a buzz that happens in the Capitol and it gets picked up, and it's almost like, it's like, I always say it's like high school without the lockers, but it is like that, whatever the hot issues are get talked about, even if it's not your issue. Like, I might know that it's an Indian gaming issue is the hottest topic of the end of session because that's what everyone's talking about in the hallways or, at lunch or whatever. And there was none of that. So you can't create this sort of buzz when there's no bees. there's nobody to be talking about it. And so it made it very difficult. We've also really relied on a strategy of having, several really strong champions for our issues. So not having, there are 120 legislators, not having 120 legislators be our best friends, but to have, 10 really strong advocates. And that has really worked for us. But in this particular context, they're not able to lobby either. So we rely on them to sort of be our surrogates with their own, with their peers. And they weren't able to lobby each other either because they weren't physically sitting next to each other on the floor, which is, how it happens. And so it was just a dramatically different experience than when we've had before. And so I think it's important for people to recognize that while we were not successful in getting that exemption, I don't read it as a rejection of the argument. I think it really had a lot more to do with the circumstances that people weren't willing to say, I won't vote for it unless you exempt, which is ultimately what you have to do. You have to be willing to create the pressure to stop something, unless you have the exemption. And I don't think that momentum existed, but I don't think it's because people rejected the argument, which is important.
So we have until December 30th for the governor to either sign it or to veto it. And, unfortunately, we are concerned that he will sign it, but we'll see. So the board will meet in November. If it is signed, we'll have to figure out what our next steps are in terms of fighting this. But we will continue to fight, and we'll continue to fight for any issues that affect emergency medicine.
So I encourage you all to get involved. I hope all of you have taken action on our action alerts that we've sent thus far. And hope you've done so to lobby the governor to veto the bill. I encourage you all to get involved either on a particular piece of legislation that you're interested, like this one, or to our lobby day, which hopefully we'll be having in some capacity in the spring, either in person or virtually. And then, you know, I realized that not everybody went into medicine wanting to be a legislative advocate, you know. So if that's not your interest area, please know that, you know, we're your insurance policy. There are folks who are doing this on your behalf so that you can go and practice medicine or whatever your interest areas are. You know, we've got your back. So get involved if it's something you enjoy, and if not, be glad we're here for you, and please keep supporting our efforts to do this work on your behalf.
All right, and now we'll open it up for questions. Thank you.
That was a really interesting talk. I learned a lot about some of the amazing advocacy work that Cal ACEP is doing on our behalf. And I actually have a couple of questions. Vivian, the immediate past president of Cal ACEP, who you just saw in the video, is here with me live. And I want to throw a couple questions at you, Vivian. Okay, as I was listening to this, I didn't realize how much COVID and all the social implications and physical distancing as a result of COVID impacted this bill that we're fighting so hard to prevent from getting signed into legislation, AB 890, which was a focus of a good portion of your discussion with Elena. And you kind of gave a little hint at the end about, you know, if it gets signed into law, what are some of the things that Cal ACEP can do at that point? What are some of the ideas of how do we go forward once that, if that is passed, and hopefully it's not, hopefully everyone clicked on that pop-up link and you're all gonna send a message to the governor to try to prevent him from passing it, him to veto it. But do you think you could talk about what are some of the things that you might do as Cal ACEP to counteract that, or what, I don't know, what can we do if that's signed into law?
So I think we have a few options, but I think the biggest one would be to work for an exemption, because as we mentioned in our discussion, this was really meant for primary care and access to primary care. And so, you know, even though it's passed, we know that the intention was access to primary care. I think that to have pulled us out and to get into the nuances leading up to all of this that has happened, it would have taken too long. But once it goes into law, or once it's signed, we will have time to figure out, okay, well, how can we pull ourselves out of it? And I think that, like Elena said, it wasn't the, you know, what we were saying, it wasn't really the content of what we were saying. It's just, you know, things happened really fast and we just didn't have the time to get ourselves exempt. So there are a lot of merits to why we shouldn't have nurse practitioners practice independently in the emergency department. And so we will have to figure out, you know, how to build legislation around that exemption. And so I think it's definitely possible. I think that I honestly, I just don't think a lot of legislators want that, you know, the things that would be enabled by this bill. Namely, what Elena said is that this bill would not prohibit emergency departments to be completely run only and solely by nurse practitioners. And so I don't think that that is what they envisioned when they passed this. And so that's what we would work on is, you know, more of the nuances, and we'll have the time to do so.
Now, I know we still have a few more days to try to reach out to the governor, and a little pop-up came up during that talk that you could click on, but there are so many other ways that you can find information on how to do this. So if you missed that pop-up, there's been a number of emails from Cal ACEP with instructions on how to reach out to the governor. And there's also, if you go to the handouts tab, there's some information there on Cal ACEP. You can go to the website. Vivian, what can people do who are listening right now? What else can we do to try to prevent this from getting signed into law?
Well, the, you know, reaching out to, using our pop-ups are really going to be helpful. I also just think, even if we can't stop this from being signed, setting the message and sending the message now and socializing this around about making that distinction of why emergency medicine is different is huge, because we can certainly do work to sort of get us ready for the next phase should this be signed. So please answer our action alerts if you can. I think that's going to be extraordinarily helpful, and just keep talking to your colleagues. The more people understand about this, the better.
There were so many things I learned from listening to you and Elena. Another thing that was interesting, just hearing the journey over the course of the year, how you started out with a certain set of issues, and then things shifted with COVID, and then they shifted again with AB 890. One of the things that Elena and you had mentioned was about liability protections during COVID. And I'm guessing, trying to read between the lines here, a lot of that has to do with telehealth. And sort of these quick visits that we're doing for screening for COVID testing. I wanted to ask, how do you think that's going to affect our specialty long term? Do you think, telehealth seems to be really important right now, and I kind of hope that carries forward because I think it can play an important role. But how do you think liability and some of these newer things like telehealth is going to affect our specialty moving forward?
So I think it's really two things. So let me tackle telehealth first. I definitely think it is coming, and it will affect our specialty in some way. And I know that the Cal ACEP board will be focusing on that this coming year. We need to figure out, what is our role in telehealth? And I also think that we as emergency physicians should embrace it, because the more that we can sort of expand our scope within emergency medicine, the better. It gives us more practice modality opportunities. So one, I think definitely we need to embrace telehealth, and I think that we are well positioned to do so. As it relates to liability, I think that as we figure out where we will be, how do we want to play in this space of telehealth? Once we figure that out, then we need to make sure that there is liability protection that then accompanies that. And I do want to just talk a little bit about the liability protection as it pertained to COVID as well. All of you who are listening to this and practiced emergency medicine during the early days of COVID, and even actually now, we were not practicing the standard of care. Before COVID, we could actually test someone for influenza. During COVID, we didn't necessarily, or there were some tests that we normally would have done, and we simply didn't because of COVID, or perhaps we weren't giving nebulizer treatments where normally we were. So there was a very distinct change in our medical practice when COVID came about. And we really, are not protected for that. And so that was part of the liability protection question that went into that. I think it's a little less so now as the pandemic has progressed, but those are the type of liability protections that we were really seeking.
Yeah, that's really interesting. It really did change, I think, the way we practice emergency medicine in those early days, and we were bracing for this onslaught of huge numbers of patients, and maybe not ordering as many x-rays, or maybe not doing in-person exams in some cases. It really kind of shifted. It seems to be getting closer back to normal now, although still definitely not normal, but I definitely feel that, what you're describing. Yeah. Do you have any final thoughts or anything else you want to mention before we move on with the program?
I would actually. I do want to encourage everyone to, even if advocacy is not your thing, but I would encourage you just to start looking at some legislation. You'll see, Assembly bill, blah, blah, blah. So AB, whatever, or Senate bill, whatever, SB 1152 or what have you. Start looking at those and pick one that is interesting to you and just follow it. Because I'll tell you that when I was a resident, I wasn't that interested, and I would see AB 52 or, SB 6, and I would sort of glaze over. But now I recognize how important it is for our specialty, because these are legislators that are making decisions about our practice, and they have no idea what it's like to be an emergency physician. physician. So it is so important to have our voice. So maybe it's not your voice, but it's going to be one of your colleagues' voices. And I really encourage you to at least look at one bill that interests you, follow it through, see how the legislative process works. And I also want to encourage you to attend our legislative leadership conference. So that's in the spring, that's through California ACEP. And when we're not in COVID times, we actually physically go to the Capitol and we meet with legislators and talk about our issues. And it is so eye-opening to see how little they know and how much they respond to just everyday stories that we can tell about our daily practice. And then lastly, I also want to just mention that National ACEP also has a leadership and advocacy conference, so LAC, where you actually go to DC. So those of you who have more interest in it, I would definitely look into that as well. So those are some options for you. I hope that we will see you at the next LLC in spring. And I just want to thank you for your time today. And Jess, thank you so much.
Thank you. There are so many things that go on behind the scenes that, you could live your life and work your shifts and do your job and have no idea this amazing work that's being done on our behalf. So thank you for giving us that insight. Thank you for your service as the immediate past president of Cal ACEP. And thank you to Elena, the executive director of Cal ACEP. So we're going to continue on with the rest of our general session here. We're at the tail end. We are actually going to spend a couple of minutes talking about the poster session. Now, in the last couple of years, the poster session is something that we had just recently introduced. It's the Innovations Poster Session, where you get to share any innovation that you've brought to your emergency department or to your educational curriculum in any capacity. So that's sort of a new thing. And we wanted to try to continue that, even though it is a digital format this year. So we still have great posters, but you don't want to hear this from me. Let's hear from our poster track chair, Dr. Andy Grock, who's going to explain how the poster session is going to work this year.
Hey everyone, my name is Andy Grock. I'm faculty at the West LA VA and assistant professor of VM at UCLA, and I'm this year's 2020 Advanced ED poster chair. So I first of all want to thank everyone who helped plan the conference, Jessica Mason, Natasha Wheaton. I wanted to thank all of you for coming. I hope you're learning something valuable and getting as much out of this conference as you can. And I wanted to thank our poster presenters who came up with excellent research and education innovations that I am lucky enough to bring for you today. Now we did something kind of fun. We hope you enjoy it, where we had each author film a video themselves explaining their poster, and that's packaged actually with like a one-page abstract if you want to delve into the details or see that content in written format. Now, I want all you guys to go out, I want all you guys to look at this poster and sort of whet your appetite and get your curiosity humming. I'm going to just briefly introduce each poster. So first we have Nicole McAmis, who did a needs assessment on healthcare provider knowledge of human trafficking. If you don't think of human trafficking, you're going to miss it. So very important poster, very fun, interesting work. Next, we have Gregory Goldner, who has a methodologically exquisite abstract talking about sort of the root causes of burnout and what really correlates well with burnout. Very important if we're going to try to take steps to fix this problem. Next, we have Dane Zappa, who did a needs assessment on resident knowledge base on QI and patient safety. Chase Richards did a COVID-related one where they did a virtual book club among their residents for faculty development. So in the era of COVID, you can still do things like book clubs. You just got to do it virtually. And he's going to talk about some of the data on how it went. Next, we have Louis Wang, a med student actually from UCLA, who's going to compare day versus nighttime ECMO activations. Charlie Burke gave a wonderful presentation on maximizing mentorship. So how to be a good mentor, how to be a good mentee. Not an often talked about topic, so one that you might want to watch if you're hoping for a career with any mentoring or menteeing. So thank you, Charney. Jesse Werner, the med fellow from UCSF Fresno, is how to podcast and how to make podcasting an educational initiative and curriculum. So really interesting stuff if you like podcasting. Manuel Celadon has another COVID-related presentation where they had to redeploy non-EM providers into a disaster medicine COVID tent, and he talks about a sort of online app or website that you can use to navigate where that patient can go based on specific characteristics. Next, we have Sarah Kozer, who's a resident at UCSF Fresno, and she actually talks about a ACEP-related free app for a curation of COVID-19 information and resources. So you guys can check out that poster and download that today. And lastly, we have Ashley Ryder, who's the Sim and Education Fellow at Stanford. She talks about creative ways to get med students education in our ER in the era of COVID where they might not get the hands-on approach that they usually do. So very creative, very interesting. These are some absolutely wonderful presentations. I'm very proud to have been a part of bringing them to you, even though obviously I take zero credit. So that all being said, I'd like to pass the mic on to Haley Minella. She is our poster vice chair, and she's going to be talking about who won what prizes and why. So congratulations to all of you, and I want all of the audience to check out these excellent posters. Thanks. Have a nice day.
Thanks so much, Andy. Hi, everyone. I'm Haley Minella. I'm a recent graduate of Stanford Emergency Medicine Residency, now an administrative fellow at OHSU in Portland, Oregon. I had the pleasure of serving as vice chair for our poster session this year, and I now have the honor of presenting the awards. First, again, thank you to everyone who submitted this year. You all did fantastic work, and we loved hearing about your projects. Our first award goes to Best On-Screen Performance. Chase Richard, the introduction to your presentation was both engaging and humorous and really caught the attention of the watcher. I think that we all look forward to either starting or continuing book clubs at our institutions this year. Next award for Best Education Innovation goes to Ashley Ryder. We really enjoyed hearing about the tips and tricks that you have to engage students in the era of COVID and look forward to using these on our next shift. Last but not least, award for highest impact goes to Sarah Kozer. We felt that the application you've helped develop will be able to provide invaluable up-to-date knowledge for any practitioner taking care of patients with COVID and will really impact their care. Congratulations to all of our award winners, and again, thank you to everyone who presented this year. I encourage everyone here at the conference today to take the time to watch their presentations and take a look at their abstracts. Thank you for your time, and I hope that you enjoy the rest of the conference.
Thank you to the members of the 2020 Awards Committee. The Cal EMRA Award. Dr. Daniel Udrea is a third-year resident at Loma Linda and has been a relentless advocate for his fellow emergency medicine residents. He's a dedicated member of Cal EMRA, serving as their membership director and running their social media presence for the last 2 years. He has also made an impact on Cal ACEP as a member of the annual conference planning committee, ensuring the resident perspective is well represented. Dr. Udrea is a hardworking, committed member who is selfless and truly gives to his co-residents and residency. The Education Award. Dr. Stuart Swadron has earned the nickname Captain Cortex because he is a clinical genius and can translate his skills as a clinician into education. Whether he's teaching at the bedside, on a stage in front of thousands, or on camera, he connects with his students and audience. Dr. Swadron does not just teach facts and the what, he teaches the why. His casual way of approaching complex problems allows him to communicate the nuances of medicine in a way that makes it click and stick. Dr. Swadron is always willing to embrace students, residents, fellows, and junior faculty. There is no better example of a mentor. The EMS Award. Dr. David Duncan has dedicated his career to improving EMS care. He has served in a number of capacities, including Aeromedical Representative for the EMS Medical Directors Association of California, Medical Director, CalStar Air Ambulance, Medical Director for CAL FIRE, current EMS Agency Director for California, and many, many more. His work and service has been recognized with multiple prior distinguished awards. Dr. Duncan has an unwavering commitment to California's EMS system and those providing emergency care. The House of Medicine Award. Dr. Race Vora became the interim Fresno County Health Officer in February of 2020. Little did he know he was assuming this key leadership role in the weeks leading into the COVID-19 pandemic. Dr. Vora has worked tirelessly under these stressful circumstances to enable testing, communicate with local hospitals and clinics, expand medical care facilities to arenas and fairgrounds, develop plans to care for the homeless with COVID, work with local and state government officials, and communicate regularly with the local media to provide updates to the public. Dr. Vora has done all of this and more with a smile and a calm, collected approach. The Humanitarian Award. After graduation, Dr. Daniel Kodabach joined the International Medical Corps in responding to the earthquake in Haiti in January 2010. Dr. Kodabach's work in Haiti included teaching, capacity building, developing innovative disaster response, and strengthening the pre-hospital system in areas that had been devastated by the earthquake. He was central to IMC's response in the cholera outbreak in Haiti, an emergency within a disaster. The common thread running through his tapestry of a life is his wisdom and kindness beyond his years, and his embodiment of the qualities of the ideal physician. The Key Contact Award. Dr. Attila Uner serves as Cal ACEP's appointee to the Los Angeles County EMS Commission and the California EMS Commission, of which he is also the vice chair. He has been an outstanding source of leadership and guidance on EMS within Cal ACEP. Dr. Uner's work representing Cal ACEP on the LA County and California EMS Commissions and insights have been exceptional. The Media Award. Dr. Nicholas Sawyer has been an advocate for Cal ACEP and emergency medicine on social media, especially sharing personal experiences and dispelling misinformation during the COVID-19 pandemic. He has also been quoted in multiple news articles because of his tweets dispelling myths about COVID-19. While Dr. Sawyer's social media advocacy focuses on more than just COVID-19, he's had a substantial impact educating the public during the pandemic. The Senator Ken Maddie Political Leadership Award. Senator and Dr. Richard Pan has been a tireless defender of the practice of medicine as a state legislature and chair of the Senate Health Committee. He has been an ardent supporter of public health, especially vaccinations. He has stood by physicians in every debate over scope of practice, even when he was the only vote. Dr. Pan is a defender of medicine and emergency medicine and has shaped the debate in the California legislature. The Special Recognition Award. Dr. Vik Gulati felt that he had to do something more when the COVID-19 pandemic hit. He partnered with others to develop a nonprofit organization called Charge, which collects donations from the community of cell phone chargers of various types. The phone chargers are given to patients who are isolated due to COVID-19 and have no other means of contacting their family and friends if they cannot charge their cell phone. Dr. Gulati took an idea and made it a reality, playing an important role in combating the loneliness epidemic of COVID-19 patients. The Walter T. Edwards Meritorious Service Award. Dr. Andrew Fenton's years of service to the chapter include 1 year as one of the chapter's first advocacy fellows, 8 years on the board of directors, and 1 year as president. During his time on the board and as president, he brought a heightened awareness to the issue of firearm injury prevention, ushering in Cal ACEP's firearm policy in 2016. He also championed other public health issues, including drug overdose prevention and pediatric trauma care. Even after his presidency, Dr. Fenton has been an active champion of emergency medicine and Cal ACEP, and his leadership has had a profound impact on the organization and the patients of California. Congratulations to the Cal ACEP 2020 award recipients. Well, a couple other thank yous that I have to put out there. First of all, that beautiful video that we just saw acknowledging our award recipients and some of the other videos that you saw and will be seeing today. I specifically want to thank Graham Smith, who did the editing. He works for MRAP, and that was part of the sponsorship through MRAP. Graham put a lot of time into making those, so thank you, Graham. Our award winners are going to be getting a really beautiful plaque in the mail, and you should hopefully be getting that soon. So congratulations to the many award winners, well deserved. Now we are going to take a brief break, just a 5-minute break. And when we come back, we're going to focus on the residents. We're going to do the resident track. So we have a whole program to talk about, what it's like applying for a job and how do you manage your finances and a whole bunch of issues that we hope will be very interesting for our residents out there who are listening. So we're going to take a 5-minute break. And before we go, we just want to acknowledge and thank our sponsors who helped make this conference possible and free. And so we're going to just watch this brief sponsorship video, and then we will resume the program here in 5 minutes.
Spend more time caring for patients and less time with your fax machine. With the AIM Snap Send feature from Vitas Healthcare, clinicians can refer seriously ill patients quickly and securely with a face sheet photo and a few clicks. Take the guesswork out of hospice eligibility decisions. The leading hospice app features a new and easy-to-use palliative performance scale to recognize signs of functional decline in seriously ill patients. Refer hospice-eligible patients to Vitas Healthcare securely and confidently. With just a tap, the referral history helps clinicians check on the status of hospital referrals, including confirming the referral was received successfully. Download the leading hospice app today.